SSBD live webinar on transfusion medicine, which is done with a unrestricted support from Sanofi. I would like to thank the 140 attendees who joined us today. I would like also to thank renowned experts who will be sharing their time with us today. So this is the program, and I would like to announce that the full recording of the webinar will be available through SSBD communication channels in the YouTube, as well as in Twitter account, Saudi Blood 1 for the Twitter, and the YouTube Saudi Blood. Without any further delay, I would like to call Dr. Almohammadi, who is the chairman of Department of Pathology in King Abdulaziz Medical City in Jeddah, to chair this webinar. Dr. Almohammadi, the floor is yours.
Thank you. Thank you, Dr. Firas, and really honored today to be on, moderating such a session that will serve a great purpose during this pandemic. Dr. Arwa Alriyami is a colleague from Oman, a consultant hematopathologist from Sultan Qaboos University Hospital. I know her very well as we wrote our Royal College exam together, so she cannot hide anything about when did she graduate and what's her age. Very important person in terms of transfusion medicine in Oman and in the Gulf. And she will be talking today about the role of convalescent plasma therapy in COVID-19. The floor is yours, Dr. Arwa.
Thank you very much, Dr. Muhammad. Thank you, Dr. Firas, for inviting me. I just want to make sure if everyone can hear me clearly and can see my screen at the moment.
I think, yeah, we see that and it's clear.
Perfect. So today I'm going to give an overview on the use of convalescent plasma therapy in COVID-19 patients. And we know that this is a global health crisis at the moment that has been considered pandemic by WHO since March 2020. Total confirmed number of cases have reached about 2 million, and there is a large number of deaths that have really occurred across the world. Human-to-human transmission involves multiple routes, including droplet transfer, direct contact, and indirect contact. And the virus itself has some similarity to SARS-CoV genome. And up to date, there is no approved options for prophylaxis nor for therapy. Now, looking at this table here, comparing the different types of viruses, you can realize that these viruses do have similar primary reservoir. They do have different reservoir and variable degree of human-to-human transmission, which explain the difference in the pandemic potential between these viruses. The incubation periods appears to be also overlapping, and they all are associated with pneumonia infection. Now, SARS infection by itself was a severe infection. It was associated with 774 virus-reported deaths, and mild illness was uncommon in particular. However, MERS was associated with higher degree of lethality in comparison to SARS. Although COVID-19 was associated with milder symptoms because of the high pandemic potential of this virus, collectively it has caused more deaths compared to what SARS and MERS have caused collectively in the last years. Now, convalescent plasma use is historically been used to different viral infections, and this has been used either as a prophylactic measure to prevent clinical infection or blunt clinical severity in patients who have been exposed to pathogens in any certain way, or it can be used therapeutically to provide passive antibody administration that can be offered as a short-term strategy in treating patients. There are many viral infections whereby both indications were used as listed in here. And from the experience of these outbreaks, the idea of using convalescent plasma came in for COVID-19 infections, considering the similarity between the virus and the other coronaviruses. However, it's important to keep in mind that data from rigorously controlled trials are very few. So the idea is to collect the IgG neutralizing antibodies with relation to the peak level in the serum of an infected individual during the convalescent phase and induce that into the recipient, either for post-exposure prophylaxis or for treatment. And since the similarity, as I mentioned, it's a promising treatment option as it appears for COVID-19 patients. Looking at the major structure protein of SARS-CoV-19 in details, you can see that there are a couple of proteins on the surface of the lipid bilayer of the virus that are associated with activations of the T cells and inducing immune response. And the most important proteins out of this is the spike protein. And here there is similarity in the structure of the spike protein that can be seen between COVID-19 virus and SARS-CoV virus. Both of them do have a subunits, S1 and S2 subunits, with S1 subunit being most important in provoking a T cell response, specifically at the RBD section. Now, how that basically induces the idea of use of convalescent plasma. Now, the virus itself initiates cell fusion via the attachment of this S protein with the ACE receptor on the surface of the alveolar epithelial cells. And after this attachment takes place, the virus gets delivered inside the cell and it undergoes the subsequent replication. The S protein itself is the main target for the antibody-mediated neutralization, and that in specific is against this receptor binding domain, which is seen here in this diagram. And hence, neutralizing antibodies do block the binding by specifically addressing and targeting this RBD section, and hence you are blocking the fusion of the SARS-CoV-19 and its internalization into the target cells. Now, with regards to utilization of convalescent plasma in prior viral infections, this is the largest study that involved the treatment of 80 patients who received convalescent plasma in Hong Kong for SARS infection. This was not a randomized trial, and titers were not performed on the plasma that was used. Patients were treated before 14 days as much as possible, and the mean volume of plasma was 279 with a range of 160 to 640. The authors of this paper did report good clinical outcome in 41% of the patients defined by hospital discharge by day 22. And you can see that younger patients did have a better outcome compared to older patients who received convalescent plasma. And also patients who received the plasma treatment earlier in the course of admission did have a better outcome compared to those who received it later on. And there were no adverse events that were reported by the authors. As for use in H1N1 infection, the study was done on 91 patients who were recruited for this treatment. 20 patients actually received the convalescent plasma, and the plasma that was used did have a neutralizing antibody titer measured and ensured to be above the 160. The authors did report that the convalescent plasma did reduce mortality with the odd ratio of 0.2, and it also was associated with significantly lower viral load at day 3, 5, and 7 compared to those patients who did not get convalescent plasma. And it was also associated with lower cytokine levels and interleukins and TNF-alpha. And as here, it appears in the diagram here, the comparison between the viral load of those patients who were treated with convalescent plasma in comparison to those who were not treated with convalescent plasma. And you can see the steeper decline in the viral load in this group of patients. Again, the same comparison is seen for the TNF-alpha for those who received the convalescent plasma versus those who did not. And you can see the decline in the TNF-alpha in this group of patients. And again, there were no adverse events that was reported in this study. Now, this is a systematic review and meta-analysis looking at the different observational and randomized trials that looked into the use of convalescent plasma in different coronaviruses as well as influenza viruses. And it did include a large number of studies. And when they did the pooled effect on the assessment on the effect of use of convalescent plasma on the mortality of patients who were treated on this arm, it was found that the mortality was reduced after receiving various doses of convalescent plasma in those patients who had severe acute respiratory infections with no serious adverse events or complications following this treatment. However, the authors of this meta-analysis did clearly report that there is lack of high-quality studies that looked into the use of convalescent plasma in the previous viral infections. In addition to that, there is a moderate to high level of bias that has been seen upon assessing of these studies. Now, coming to coronavirus COVID-19, there are 2 reports that came in with China with the use of convalescent plasma in this group of patients. This is an uncontrolled case series of 10 severely ill patients who received convalescent plasma at a dose of 200 milliliter. They have used a neutralizing antibody titer, which is above 640. They did to pathogen inactivation of the plasma before use. And these patients did receive other therapies, including steroids and antivirals in their course of treatment. All 10 patients were showed improvement in their symptoms within 1 to 3 days after the use of convalescent plasma. And in addition to that, they have shown objective improvement with regards to their respiratory performance, weaning off ventilation, improved oxygen saturation, and radiological improvement of pulmonary lesions. In addition to that, 7 out of these 10 patients had undetectable viral load within 2 to 6 days of treatment, and half of the patients also had raised neutralizing antibody levels compared to the levels of the antibodies prior to treatment. So looking at the CT scans of a couple of those patients, you can see patient number 9 here. This is a CT scan that was taken at day 7 post-illness prior to receiving the convalescent plasma. You can see the lesions here that are present in this section of the CT scan. And after receiving the convalescent plasma, you can see the resolution of these manifestations on the CT scan. And this patient in particular did receive the convalescent plasma treatment quite early in the course of their admission. In comparison to this, this patient did receive the convalescent plasma quite late, and you can see that the resolution prior of the lung lesions appears to be less less in terms of resolution compared to the prior imaging studies that were done when we compare that to the first patient. So earlier treatment is associated with better outcome. And there were no adverse events that were reported in this particular case series. In addition to this, the authors did show that the change in the laboratory parameters of those patients prior and after receiving the convalescent plasma. You can see that the CRP levels have dropped in those patients. They had improvement in their lymphocyte count and in their saturation levels. And there is improvement in their liver enzymes as well, compared to the values that were recorded prior to CP treatment. And this table here does show to us the difference in the serum neutralizing antibody titers prior and after receiving the convalescent plasma for the group of patients that did show improvement in their titer. So you can see that the titer levels have really gone up in half of those patients after treatment, and all of the patients did not have any detectable viral at the end of their treatment. The second study was an uncontrolled case series of 5 critically ill patients with ARDS. These patients had severe pneumonia with rapid progression and continuously high viral load despite antiviral treatments. They did receive 2 consecutive transfusions of 200 to 250 ml of convalescent plasma, and these were administered 10 to 22 days post-admission. The authors did had in their trial measuring of the IgG levels for the plasma before use, and all of these patients also did receive antiviral treatment as well as methylprednisolone. In this case series, they have reported improved outcome, again, respiratory improvement, as well as normalization of body temperature, reduction in viral load, and increase in the antibody titer levels in the recipients. And this is shown in here in the different diagrams with the improvement of the SOFA score of these patients, as well as improvement of the oxygen level, normalization of the body temperature, and increase in the antibody levels. Now, this is definitely limited by the study design and the concomitant treatment modalities that these patients did receive. And there is a broad range of treatment timing that these patients did receive convalescent plasma, which could have also affected the outcome in the treatment. So if a center wants to get this for treating patients, what are the requirements? And this is basically the general requirements that are really required. You need to decide whether if this has to be a prophylactic protocol or a therapeutic protocol that need to be within a clinical trials setup, certainly meeting the safety and the quality criteria with the established standards to produce this product. You need to have the population of donors who are covered from the coronavirus infection to collect the convalescent plasma, blood banking facilities and virology testing, as well as the availability of the assays to measure the neutralizing antibody levels, and regulatory compliance depending on where you are. As per FDA, this is now regarded as an investigational product, and as a result of that, the application for treatment depends on the setup that is being used, whether if it's in a clinical trial level or on a compassionate use. The donor eligibility, so who can basically donate and at what time they can donate convalescent plasma. The donor need to have a history of COVID-19 infection, obviously, and that can be confirmed or approved by molecular testing by nasopharyngeal swab. By the time of donation, the donor needs to be safe to donate blood, considering that they will be in contact with the staff as well as with other donors in the donor room, depending on the setup that you would have. And this basically would mean that this donor need to be a minimum of 14 days after resolution of symptoms and have a negative follow-up molecular test for SARS-CoV-19 by nasopharyngeal swab. And ISBT in the initial guidelines that they published on regards of recommendation, they also recommend that this has to be done on 2 different intervals, at least 24 hours, to ensure that the donor is virus-free. Now, in order to reduce the risk of TRALI, we use the same criteria for donor selection of using either male donors or female donors who have never been pregnant, or females who have been tested for anti-HLA antibodies and found to be negative. And obviously donors need to meet also the other donor criteria. And if this is within a clinical trial, which is recommended to be, then they have to sign an informed consent of enrollment. Now, FDA and AABB have also released a revised criteria into who can be considered as a donor eligible. And this was released just earlier this month as a revision of the initial release that they have published in March. The documented diagnosis of a donor basically now, as per AABB and FDA, can include either having a diagnostic test by nasopharyngeal swab, or you can have someone who had been confirmed to have serologically antibodies that are detectable after recovery, even if they have not had any diagnostic testing. And I think this have been incorporated considering that there is a situation in many countries whereby the testing is basically running out of the laboratories as well. Now, recovery of the donor would include 3 different possibilities: either complete resolution of the symptoms at least 28 days prior to donation, and in that the case, you don't need to do any further testing on the donor, or you complete resolution of the symptoms at least 14 days prior to donation, and you have to have a negative COVID-19 test, either by 1 or more nasopharyngeal swab or by molecular diagnostic test in the blood. And they have added this component as well now in their criteria. You have to have, you can also collect donor before 14 days if they are symptom-free and they have 2 negative test results on different days. And the caveat behind this is that donors may not have the peak antibody levels before 14 days, and hence you may not have the same influence or impact of this convalescent plasma as you would want if you have collected it 14 days or after. The same criteria applies for TRALI protection, and they also require that you have to have neutralizing antibodies that are tested if it is available with the titer that is indicated in here. However, if this test is not available, then samples can be collected and can be archived and tested at a later stage whenever the test is available. Now, looking at the Europeans on the other hand, and what's their recommendations with regards to documented diagnosis and recovery. Documented diagnosis on the European Commission guideline is to have a prior diagnosis of COVID-19 documented by a lab test or by a clear history of COVID-19 symptoms when testing is not available. And this is again having a layout of who can be enrolled into this if testing is not available. Recovery of the donor can be either at least 14 days should have been passed since the full recovery, or at least 14 days after lab evidence of viral RNA clearance of the upper respiratory tract, or could be 14 days after being out of a quarantine or an isolation period due to suspected or confirmed diagnosis of COVID-19. And they have a different cutoff value for neutralizing antibody. In fact, the Europeans are more stronger in their recommendation on measuring the neutralizing antibody titers, and they recommend a titer that is more than 1 in 320. However, they lower titers are considered to be also acceptable. If testing for neutralizing antibody titers is not available, they are actually allowing to test using the ELISA methods, which I will highlight later in my slides. And if the plasma need to be used on emergency cases and none of these tests are not available, then you can go ahead and use the plasma within the clinical trial and test the plasma aliquot samples at a later stage whenever the tests are available, because these tests, many of these tests are still under development and validation at the moment. Now, how the plasma is collected from the donor, that can be a whole blood or apheresis, but preferably apheresis. Apheresis gives you a higher volume that can be collected. It minimizes the blood loss in the donor, and the units can be then splitted into the volumes that you want and can be frozen and stored until its later use. And how frequently the apheresis would depend on what do you basically apply for in your center. So generally, an apheresis donor may donate plasma once every 28 days, but you can do that even at a higher frequency with approval from your medical director. And European Commission guideline clearly did recommend that you split the unit after the apheresis and you basically freeze it out and use it in the separate doses based on your trial protocol. And whole blood can be used, and it has been used in different countries whereby apheresis facilities are not available. Now, coming to antibody testing, it's uncertain to which antibodies are optimally effective in COVID-19 and what titer limit I should basically use.
Arwa, if we can just minimize the, what is left to 1 minute maximum, on time, and I have a lot of interesting questions for you as well.
Okay,
from the
no problem. So neutralizing antibody assays are the best to be used, but they are likely to correlate better with the recovery and protection, but these are more difficult to be available because they're not available on commercial use. And quantitative assays are the ones that are available, but they are not rigorously validated. And many of these assays are undergoing testing at the moment. Coming to pathogen inactivation, whether to go or not to introduce pathogen activation, it is highly a difficult question to address at the moment. However, despite that the studies have shown that you might detect viral RNA in the testing donor and the tested donors with the different types of viral infections, that does not necessarily mean that you have an intact infection. And hence, it's a theoretical risk of transmission that we are addressing in here. And hence, the recommendation is to use it whenever it is feasible, but if it is not possible, many centers have gone into use convalescent plasma without it. The patient eligibility is variable. So FDA basically includes severe COVID-19 and life-threatening COVID-19, while the Europeans include any patients who are hospitalized with an acute illness. And it should be used within as early as possible in the disease, preferably within the first 10 days. And the volume methods is also appear to be variable and does vary between the different trials. And there are pediatric protocols that are coming out as well. And the dosing in these pediatric protocols are based on the weight of the patient. These are the outcome measures that can be measured. Some of these are clinical and some of these are laboratory based. And it's very important to highlight what outcomes you would measure and also whether if you would measure the viral levels and the neutralizing antibodies after transfusion. Potential risk out of these, and these are my last slide. You need to remember that there are plasma-related risks, including TRALI and TACO and anaphylaxis. Risk of transfusion transmission of COVID-19 is really theoretical for the reason I have mentioned, especially with the fact that you collect the donor after 14 days, and there hasn't been any report of transfusion of respiratory virus by transfusion. And this is another theoretical risk, which is antibody-dependent enhancement. It has been very known for other viruses like dengue infection, but there are no reports of similar reaction that have happened with SARS or MERS or COVID up to date. I would skip this workflow, but this is basically address the full workflow of how do you do it. And I will conclude by saying that this is projected to be an effective therapy throughout neutralizing viremia in severe cases. It has to be done within a controlled clinical trial. Optimal dose and time points appears to be not very well defined, and it has to be assessed really in different types of trials. And it's very important to evaluate its use objectively with a different range of indications. And it's very important also to remember that there is a lot of data that is coming out there, and hence these recommendations can be dynamic and vary with time. And with that, I thank you everyone for your attention.
Thank you very much, Dr. Arwa. As comprehensive and exciting as usual. I think the message is clear in your presentation. And I have been watching the questions coming, very interesting questions that we will save, inshallah, to the last session of this webinar for the Q&A. And we will go from here to our next, who was supposed to be the first speaker, again, Dr. Syed Osman, who will speak about a very important subject, very dear to my heart, contingency planning for blood transfusion and blood banks during the, in the midst of this COVID-19 crisis. I think also Dr. Arwa Alriyami, as a blood banker and a big name in this area, would be interested also to hear what would Dr. Osman have to say. And I wish also that a lot of our colleagues from the clinical side would adhere to all of these recommendations that will, in general, minimize the usage and control rate fluctuations. So, Dr. Osman from King Faisal Specialist Hospital, our colleague in clinical hematology, please, the floor is yours again, and I hope that you can keep it this time.
I hope so. Bismillah, assalamu alaikum again. All right. So now, shall we try this again? Hopefully that works. Does that work? Can you hear me? Can I just check? Everyone hears me?
Yeah, it works.
Yes.
Dr.
Perfect.
Okay. Great, excellent, thank you. Okay, so just to go back, I'll follow on from the point that our dear colleague Dr. Almohammadi mentioned, which was that, I think we're all in this together. Usually, clinicians are on the demanding end of blood products to the transfusion lab. We want blood, we want platelets, but we understand that we're not in a time of plenty at the moment. We're in constrained times, and we all have to work together. And one of the issues that came up when we were anticipating problems was that if we give blood products to patients who are in 50% need of them, then we will deprive patients who are in desperate need of blood products. So it's a question of rationing a limited resource, and it is a question of giving the offering as much benefit to as many people and as many of our patients as we can. We would know that hematology units, especially hematology units that treat patients who are undergoing either intensive chemotherapy or transplantation, these units are amongst the largest users of blood products, whether it's blood or platelets or FFP, what have you. In addition, you have our hemoglobinopathy patients, patients with sickle cell disease and thalassemia who also have needs. So now we're in a unenviable position of having to try to ration these resources for our patients. So in the current situation, all the components of a blood transfusion service may be affected. So donors are affected because of not being able to access blood banks, but because of perhaps concerns about carriage of infection and the need to screen them, and deferral periods, curfews, lockdowns, fear of being fined if they come out outside of their area. So that's really putting blood banks in a difficult situation where donors are not coming through the door. So access is an issue, infections, etc. Then you have issues within the blood bank itself. So staff may not be able to come. There may be limitations of how many people can work. People may go off sick. People may need to be redeployed from blood bank to somewhere else. there is a whole issue of supply chains that we cannot anticipate. We do not anticipate which supply chains will be disrupted, which reagents may be affected. You may not be able to get, the Diamed gel cards because of supply chain issues. They might be channeled somewhere else. So that is an unknown as well. And then you have the issue of demand. There may be a decrease in demand because elective surgical procedures in most hospitals are being cancelled or delayed. But then you have the real prospect of, and the concern and fear of what we're seeing in many countries in Europe, with ICUs being overrun with patients with COVID, many of them with thrombocytopenias, with DIC, with bleeding. So there may be demand because of that. But even if you don't have that additional demand, we in hematology and transfusion units are dealing with limited resources and a number of patients who can't be reduced. So I'm just going to put this reminder up of a useful guide from the AABB, 5 things that all physicians and, in fact, patients should question. So things, for example, like, often it's a standard practice where we transfuse 2 units of PRBC for all patients who need a blood transfusion. That doesn't always have to be the case. 1 unit at times may suffice, especially if the hemoglobin is just under your threshold for transfusion. Obviously, we don't want to transfuse for iron deficiency if we can give iron. We don't use blood products to reverse warfarin. We use PCC, that's standard now. One aspect that we should consider on the clinical side is, we should really be thinking about maybe reducing daily labs for inpatients who are stable, who really don't need blood tests. There is evidence that daily phlebotomy, especially in large volumes, can contribute to anemia. So if we have a stable MDS patient who is in getting antibiotics, routinely we just do bloods on them every day. So we have to maybe question that. This is a patient who will need transfusions for anemia. So we have to try to reduce phlebotomy where we can. And then there's the issue of not transfusing O-negative blood except to O-negative patients, and in emergencies for women of childbearing potential with an unknown blood group. So these are just general house rules. So because of this need of needing to advise the end users, the physicians, consultants, fellows, of how to be a bit more mindful of how to use blood products, simply because we want everybody to benefit, and we don't want to come to a situation where we're depriving patients who are most in need. I think that something that's very important is close liaison with the blood bank and with your blood bank director. I mean, this is a bit like what we've seen in the car industry. They've stopped producing cars simply because they know they can't provide car spare parts. You can't produce a car without wheels or a steering wheel. Likewise, if we want to be treating patients with leukemia and transplantation, what this dependent variable is being able to provide them blood. And it's important for you to know or get an idea or be appraised of what the blood bank situation is like. And it's helpful if there's a weekly or twice weekly liaison between the head of the department and maybe the head of blood bank, just to get an idea in advance, in anticipation of problems that may arise. We should prioritize red cell transfusions, and I'll go into that a bit. Reduce demand and usage of blood products. That includes revising treatment plans for hematology patients. Looking again at your packed red cell transfusion practices and making sure that they're within guidelines, that you're not being too liberal, that you're not doing what you used to do before the COVID period, as in transfusing liberally, and looking at when and how you're transfusing platelets. So, for example, in terms of prioritizing red cells, and the NHS, the National Health Service in the UK, for example, has a green phase, an amber phase, and a red phase in terms of the provision of blood products. So if you are in a red phase, as many of our units are now, where we have a severe shortage of donors, we have a severe depletion of our blood stock inventories, then we really need to consider how we're going to treat our patients. We treat our patients to transplant now, in 3 weeks' time, they'll have a platelet count in single figures and a hemoglobin of 6. So where possible, we may need to defer transplants or chemotherapy. But in terms of priority areas for a blood bank, these are the priority areas. Elective surgery can get cancelled or can get deferred, but the patients who should get transfused in the red phase are these ones. So transplant patients or those getting chemotherapy, patients with a severe bone marrow failure, transfusion-dependent hematological malignancies, so you may need to consider lowering your threshold. If you are transfusing at a threshold of 8, you may need to go down to a threshold of 7. Where you used to transfuse 2 units, you may need to transfuse 1 unit. Transfusion-dependent thalassemia patients should still get their transfusions, but you might need to do one of a couple of things. And perhaps Dr. Arwa has some very helpful guidelines on the Transfusion International Transfusion Society website of how to transfuse the thalassemics. You may need to space the transfusions out more. If it was 3 weeks, you may need to go to 4 weeks, or if you're still staying with 3 weeks, you may only be able to give them 1 unit of blood. Now, you'd have to take into account, obviously, whether these are patients who are coming from outside the city and if it's difficult for them to come back, in which case you may need to give them their usual transfusion dose, but you may need to space it out a bit more. For sickle cell transfusions, you may need to aim for a higher target S level, 40. You might have to satisfy yourself with a sickle percentage of 40 instead of 30, but we will still need transfusions, and patients with sickle cell disease with a previous history of CVA will still need to be prioritized. So patients who need blood transfusions or blood products should continue to get them as a standard of care. We shouldn't deprive them, but we will just need to adapt our thresholds and how we give them. As I said, transfuse 1 unit at a time. A threshold of 7 in most cases is acceptable. Even in acute leukemia, a threshold of 70 grams per liter instead of 80 has been shown in at least a randomized study not to be associated with an adverse outcome. So that is an option to consider. And a threshold of 70 grams per liter is acceptable in most chronic bone marrow failure conditions if the symptoms allow it. Platelets. With the shortage of blood stocks, we're going to have a severe shortage of platelets. So if there are procedures that need to be done in thrombocytopenic patients, sometimes it may be possible to defer them. For example, often we run into issues with line removals. For example, patients who have Hickman line that they need removed. Most of these patients can be managed in an outpatient setting with appropriate line care. So where you can do that, and wait till the count recovers and just delay the line removal to later, and use 1 unit. Now, there is evidence that in the autologous transplant setting, you don't need to give prophylactic platelets, and that was as published by Stanworth et al. In the New England Journal of Medicine some years ago. But for transplants and for acute leukemia, stick to a threshold of 10. Tranexamic acid. Now, there are a number of ongoing trials, phase 3 trials randomizing tranexamic acid versus placebo in patients who are thrombocytopenic undergoing induction or consolidation or intensive therapy for leukemias. And we await the results of those trials, but it is something that is relatively safe and we should consider, especially in a bleeding patient. So with that, I'll conclude. So these are trying times for all of us. We all need to come together, and we all need to do what we can. For most of our patients, we have to be utilitarian and sensible and rational in how we use a product that is in short supply.
Thank you very much, Dr. Syed, for this concise, very, down to the point presentation that helps the whole team, namely our role as blood bankers and people who are responsible for blood transfusion and blood stocks during such an event like COVID-19 pandemic. Again, the questions will be by the end of this session. I have received a number of questions, very interesting questions to all speakers. But now it's time to switch to our third speaker, who will talk today about acquired TTP. It's Dr. David Volcarcel. Hola, Dr. David. The floor is yours. You can start now. Thank you.
Hello, can you see my screen?
Yeah, the screen is clear enough to me.
Perfect. So thank you very much for inviting me for this session. It's supposed to be there in your country, but COVID situation doesn't allow it. These are my disclosures, and I'm going to talk about a different subject. I'm going to talk about TTP, acquired or immune TTP, and I'm going to divide the next 30 minutes into parts. The first part reviewing the background, the physiopathology, and the current therapy, and the second part in which I'm going to speak about cabozantinib, which is the new therapy that is changing the paradigm of TTP treatment nowadays. First of all, I'm introducing the two main characters in this movie. The first one is the von Willebrand factor, which is a protein synthesized by endothelial cells mainly, and you can see in the slides. There are many domains, but there are three important. A1 domain, which is the domain responsible for binding of von Willebrand factor to platelets. A2 domain, which is the domain that use ADAMTS13 to cleavage large von Willebrand factor multimers, and the A3 domain, which is the one that is used to bind to collagen. The second character in the presentation is the most important one, ADAMTS13, which is also a protein synthesized mainly in the liver, as you can see. And let me go back for here. And I want to stress that this domain, S domain, is the domain where most of antibodies are directed against him. So it's an important part for you to keep in mind. ADAMTS13, as I told you before, is produced mainly in the liver, and the half-life is about 3 days. Also, we don't know very well how is it regulated, but it's supposed to be regulated at substrate level. To summarize what's happening with the interaction of ADAMTS13 and von Willebrand factor, here in the bottom of the slide, you have the von Willebrand factor, and when it is exposed to shear stress, the A2 domain becomes larger, and when it's larger, it's open to the action of ADAMTS13, which will cleavage the multimers into shorter proteins that are not dangerous into the blood. What is happening in the TTP? In the upper part of the slide, you can see the normal situation where we have the von Willebrand multimers, but Adams 13 cleaves them and liberates normal von Willebrand multimers into blood, and nothing happens. If we don't have Adams 13, those ultra-large von Willebrand factor multimers will remain bind to the endothelial and will produce the binding of the platelets in the A1 domain, producing a thrombus in the microcirculation, a platelet-rich thrombus in the microcirculation that is the responsible of tissue ischemia and the microangiopathic thrombocytopenia with the classical schistocytes and the ischemia of the different territories. We all know that in the past century, it was described the TTP classic pentat with fever, microangiopathic hemolytic anemia, thrombocytopenia, renal failure, and neurological symptoms. But we all know that currently this is quite uncommon. And what is always present is microangiopathic hemolytic anemia and thrombocytopenia. So we will observe schistocytes, the platelets dropping below, normally below 30,000, presence of different degrees of bleeding, and manifestation of tissue ischemia. And this is very important because we will observe neurological, cardiac, mesenteric, and renal disorders. It's very interesting that up to 60% of patients will present some kind of neurological manifestation from headache to confusion, stroke, or even coma. Also, cardiac is frequently involved with electrocardiogram abnormalities and with elevation of troponins. So we should try to see this as multisystemic disease. The diagnostic is not always easy. We need to keep in mind that there are many other thrombotic microangiopathies that can mimic TTP, maybe induced by drugs, Shiga toxin-related TMA, CID, antiphospholipid syndrome, different problems during the pregnancy. But it's also very important, and I want to highlight it, that TTP can also occur with other conditions such autoimmune diseases, mainly systemic erythematous lupus, or different viral infections, not only HIV, but other viral infections. So once we have the diagnosis, we also need to look for some other diseases in many patients. The gold standard for diagnosis, as I will explain in 1 minute, is the determination of Adams 13 activity. But sometimes this test can take more than 1 day. So we can use this kind of scores, trying to anticipate which will be the Adams 13 value. There are many of them. Probably the most useful one is the plasmic score that includes these really easy variables that you can see in the screen, and each of the variables at one point. Those patients who has 6 to 7 points will have a chance to present Adams 13 deficit between 62 and 82%. So it's a good surrogate marker of acquired TTP. But of course, as I just mentioned, the gold standard test is the determination of Adams 13 activity. The methods we are using now are based in the incubation of the plasma with the substrate. And the substrate, of course, contain the Adams 13 cleaving domain, which is a specific and shorter domain. And we can measure or directly the product of the cleavage, or we can measure the substrate remaining after the test. And this is an indirect way of measuring the activity of Adams 13. In any case, we will have an activity reported as a percentage in comparison with a control plasma obtained from pooled plasma from normal donors. Today, the test allows a sensitivity of 97% and specificity of 100% when we use a cutoff point of 10%. So those patients having really low Adams 13 activity, this is below 10%, we can be quite sure that they have TTP. You can see in some other thrombotic microangiopathies some decrease in Adams 13 activity, but never that low as we can see in TTP patients, as you can see in the slide in this moment. I cannot use any kind of signaling, but it's very obvious that TTP values of Adams 13 activity is clearly lower than those observed in hemolytic uremic syndrome or even other types of secondary TMAs. The other very important question is to look for anti-Adams 13 antibodies. There are two types of Adams 13 antibodies. The first one and the most common one are neutralizing antibodies that binds Adams 13 and impairs their activity. We can use inhibition assays that are measured at Bethesda unit, quite similar than like those using hemophilia, but there also exists some non-neutralizing antibodies that what they do is to enhance the clearance of Adams 13. They are quite common in TTP patients, but it's important to remind that up to 4% of the population and up to 15% of patients with erythematous lupus can also have these non-neutralizing Adams 13 antibodies. So we can try to join the information from the clinical part and from the lab part to see how can we perform the diagnosis of the patient with a TMA. If we have an obvious cause of TMA after transplant or with antiphospholipid syndrome, we should treat that. But if not, we can calculate plasmic score, but we should ask for Adams 13 activity. And if Adams 13 activity is less than 10%, we can confirm the TTP diagnosis, and then we should look for the presence of antibodies. And this is also important because those patients who don't present antibodies should be diagnosed of congenital TTP, and we need to perform further genetic studies. If not, we have the diagnosis of acquired immune-related TTP. Let's move to the therapy. Okay, before therapy, just a brief explanation of the definitions. We will define response as the normalization of the platelet counts and the normalization of LDH after stopping plasma exchange for 30 days. We will define exacerbation as those patients who respond, but the platelets drop and they require further therapy within 30 days after stopping plasma exchange, relapse when it occurs after 30 days, and finally refractoriness when there is no response after 5 days of therapy, including plasma exchange and steroids. The therapy is based on plasma exchange, and this was the therapy that changed absolutely the prognosis of TTP from 70 to 90% of mortality to 80% of survival, as you know, and it was seminar papers in the New England in the 90s. The mechanism of action is well known, but it's very important to remind that we should start as soon as possible, and we should not wait for confirmation with the suspicion of the TTP. We just need to start with plasma exchange and always combining it with prednisone, normally 1 to 2 milligrams prednisone per day, per kilogram a day. Also, there are some trials suggesting that higher dose can be more efficacious. But most of the centers, and my center in concrete, we are using 1 to 2 milligrams of prednisone per kilogram a day. Also, we are, of course, better than 50 years ago. There is still room for improvement because mortality is still up to 20%. Refractory is described between 20 and 40% of the patients in liver series. Exacerbation after stopping plasma exchange is observed in up to 50% of patients, and most of the patients remain at risk of relapse in the follow-up. So we need to improve the therapy in this kind of patients. Mortality is still a problem. We are, of course, better, but this slide is showing the experience of the Oklahoma group, which is probably the most experienced group. And you can see that mortality among TTP patients is clearly higher than mortality observed in a matched population without TTP. This is translated into a worse overall survival, of course, and you can see in the square in the right part of the slide that most causes of death in TTP patients are related with TTP. And the median difference of survival is 24 years. So we are better, but we are not still as good as we would like. Another problem is that there are some chronic morbidity that is somehow difficult to detect, but patients with TTP are more frequently having hypertension, chronic kidney disease, a higher incidence of stroke, and also depression and other neurological impairments. So how can we improve results in TTP patients? I think that we can do two things. The first one is try to predict relapses using the monitoring of ADAMS13 during the evolution, and the second part is including new therapies. Mainly, I'm thinking in rituximab and caplacizumab, as I'm talking in 2 minutes. Regarding ADAMS13 monitoring, you can see in the slide that the lowest percentage of ADAMS13 activity, the highest probability of relapse of TTP. And you can see that those patients who don't present relapse have a higher ADAMS13 activity. It's interesting that we can use rituximab in TTP patients. There are several studies discussing and presenting the data of rituximab in refractory patients with very good responses, and also in frontline therapy, reducing the days of plasma exchange and reducing the relapse rate, but probably over treatment of many patients. The other approach is to use rituximab such as preemptive therapy. This meaning that we can use rituximab in those patients who are in clinical response but remain with low level of ADAMTS13 activity. If we use rituximab in those patients, as you can see in the slide, the probability of remaining relapse-free survivor is higher, is the red curve of patients. Those patients were patients with TTP without clinical activity, but with low level of ADAMTS13 who received rituximab, and the probability of relapsing was lower than those patients who did not receive rituximab, as you can see in the blue line. But probably the most interesting drug that we have in the TTP setting is caplacizumab, which is a selective humanized nanobody directed against the A1 domain of the von Willebrand factor. This is the domain of von Willebrand factor that binds to platelets. So using this nanobody, we will avoid the binding of von Willebrand factor with platelets, so the thrombus will not be performed. This is the structure of the drug. Two binding moieties to bind A1 domain, and two very important things. The drug is specific for the A1 domain binding to GP1 beta site of the platelets, and there is no off-site binding of the drug outside the von Willebrand factor. How is the drug working? I just tell you. In the upper part of the slide, you can see how the platelets bind the ultra-large von Willebrand factors binding to the A1 domain, but in the bottom of the slide, you can see that the red circles is caplacizumab, which binds A1 domain in von Willebrand factors, and thus platelets cannot bind the von Willebrand factor, so the thrombus will not develop. This is important because also we are not directing the therapy against the cause of the disease. We are not avoiding the antibodies. This is the treatment with the prednisone. We are avoiding the clinical manifestation that are those problems that I just mentioned with neurological, cardiac, kidney abnormalities. We have two very important studies, phase 2 Titan study and phase 3 Hercules. Both were randomized, and a small difference because in the Hercules study, it was allow a treatment extension period after the first 30 days of treatment with caplacizumab. I will detail this later. This is the phase 2 study. It was single blind. 36 patients received caplacizumab, 39 received placebo, and there are the main results. You can see that the time to response was faster in the caplacizumab group. The exacerbation, this is relapse in the first 30 days after stopping plasma exchange, was clearly lower in the caplacizumab group in comparison with placebo. But after stopping caplacizumab, we observe a higher incidence of relapses in comparison with placebo, because when we stopped caplacizumab, we were not protecting patients from the disease. This is how you can see here how patients receiving caplacizumab respond faster, and platelet normalization was clearly faster than in the placebo arm. And here you can see the relapse incidence. In the caplacizumab group, you can notice that there are few exacerbations in comparison with the group of placebo, and a higher incidence of relapse after stopping caplacizumab. But it's very important to highlight that all the patients relapsing after stopping caplacizumab were those with low ADAMTS13 activity. So it's easy to think that if we maintain the therapy until we obtain the response and we obtain an increase in ADAMTS13 activity, we will continue to protect the patients from clinical manifestations. These are the conclusions, but I will summarize them at the end of the talk. And I'm moving to the phase 3 study. That is also a randomized trial, double-blind, and in this case, it was allowed to prolong for another 4 weeks the treatment with caplacizumab to allow the immunosuppression to work and to increase ADAMTS13 levels. The treatment in this case was, the randomization in this case was after the first plasma exchange. The treatment was exactly the same, initial intravenous administration and then subcutaneous very easy administration that patients even can do themselves in home once they are discharged. And of course, all the patients receive a standard of care such as institutional practice. These are the 3 with 73 patients in the placebo and 72 in the caplacizumab arm. You can see that 68% of patients completed the treatment in the placebo arm versus 80% in the caplacizumab, and this was because many patients in the placebo moved to open label caplacizumab arm. These are patients' characteristics, quite similar. Also, there were more patients in the placebo arm that were recurrent TTP, but this is not really a big difference. And again, you can see that patients receiving caplacizumab responded earlier, and the probability of have a platelet normalization was 1.55 times as likely as in the placebo arm. And very important is this secondary objective that is a composite endpoint including TTP-related death known in the caplacizumab arm versus 3 deaths in the placebo arm, recurrence of TTP, and development of a major thrombotic event including cerebrovascular, myocardial, pulmonary embolism, or spontaneous or catheter-related thrombosis. And you can see that those patients in caplacizumab arm clearly have a lower probability of developing this composite endpoint than patients in the placebo arm. If we look for relapse and exacerbations in this Hercules trial in which it was allowed to prolong the therapy with caplacizumab to protect the patient from clinical activity of TTP, you can see that patients in the caplacizumab arm clearly have a lower incidence of relapse or exacerbations, not only, and this is very important, not only during the treatment of caplacizumab, but also during the whole follow-up of the study. Once again, the patients who have a relapse in the caplacizumab arm were those patients who remain with ADAMTS13 level below 10%. So we can again think that perhaps prolonging caplacizumab treatment can protect those patients even for longer period of time, and we can discuss later in the question and answer sessions because we have some experience in this setting. There are also some other interesting secondary objectives: less plasma exchange days, less infused plasma quantity, shorter hospital and intensive care stay. And these are all, of course, secondary, important secondary endpoints. What about safety? Caplacizumab is binding A1 domain, so platelets will work worse and is expected to have an increase in bleeding, but as you can see in the slide, the increase in bleeding is very moderate, and in most of the cases were auto-resolved without major interventions and no patient requiring stopping therapy.
Excuse me for interruption, Dr. Volcarcel.
Yes.
If we can just finish within the 2 minutes, that would be great.
Yes, I can finish in 2 minutes exactly.
Thank you.
This paper was published in ASH 2 years ago, including all the patients from phase 2 and 3. And what is important from this is that with longer follow-up, all those learnings that we have from the previous studies were confirmed: lower plasma exchange and plasma use, a clear reduction in this composite endpoint. You can see the figures, 13% versus 47%, and also a reduction in recurrence of TTP during the whole overall study. And very importantly, with the use of caplacizumab and with more than 100 patients treated, there were no single patient who present refractory disease, that we all know is a very bad situation for our patients. It was also observed a faster normalization of organ damage markers such as troponins and LDH. But to conclude, I just want to make 4 final remarks. TTP, you all know, is a very severe disease. It's one of the hematological emergency. We change absolutely the paradigm with the plasma exchange, but we still have up to 20% of mortality currently in this kind of population. So we have a very important room for improvement, and the introduction of caplacizumab in this kind of patients, probably in combination with rituximab in some patients, can be very important to improve overall responses. I will finish my presentation showing you how are we dealing with TTP patients. We are currently using, of course, plasma exchange and prednisone, but we are also using caplacizumab in all the patients. Once the patients obtain response, we measure against ADAMTS13 activity and the presence of antibodies against ADAMTS13. And if activity is below 10% and the presence of anti-ADAMTS13 antibodies persists, we consider rituximab. And once we normalize the ADAMTS13 activity, we stop caplacizumab and we move to watch and wait monitoring control. And this was my last slide. Thank you very much for your attention, because it's incredible that almost 300 people are in this webinar. Thank you very much.
Thank you. Thank you again, Dr. Volcarcel, and thank you for all the speakers today. We are not done yet. We still ask you to do the polling for all the participants, and we would like to know, you to know that there will be a pop-up before leaving the webinar for you to do a survey. And now we are into our last stage of our webinar, which is the Q&A session. I'll try here to bring up the questions for each speaker, and I will start with Dr. David. Now I see a question here from anonymous attendee, and I think it's a comment. Let's see what do you have to say about this comment. And it says, is it not that the main job is done by immunosuppression, by steroids, rituximab, while temporarily blocked by caplacizumab?
Yes, in TTP we have 2 problems. We have the immediate problem of the microthrombus generating ischemia in different tissues, and caplacizumab is avoiding this. But of course, we need to correct the basal disorder, which is the production of antibodies against Adams 13. And this is the role for corticosteroids, and if it doesn't work, for rituximab.
One more question was about the usage of cryosupernatant rather than plasma. And I think this is an old option that went out of favor. What do you think about that?
Yeah, there are some reports using cryosupernatant instead of plasma. In my institution, we prefer to use plasma if possible in most of the patients. But if you don't have, you can use supernatant, of course.
Okay, thank you again, and I will switch to the questions for the next speaker, Dr. Osman. Are you with us? Dr. Syed?
I am with you, yes.
Okay, great. So a bunch of questions for you. First of all, everyone was apparently happy with your presentation, but what matters really is that they follow what you have said about all of these conservative measures that we are always asking for during whether it's COVID-19 or not. Since 1999, the publication of the trial, we always ask people to go with the conservative rather than liberal. In terms of transfusion medicine, liberalism is not tolerated. But I have a few questions for you. One of the question was about splenectomy. Shouldn't be deferred, because I think it's a comment, and we would like to see if you agree with that. It says splenectomy shouldn't be deferred because patients will consume more blood than prepared. Okay, we are suffering from splenic sequestration surgery, deferring them by our surgeons. I think we need to consider splenectomy as an emergency. I hope I spelled out the question right.
Right. Can you hear me?
Yes.
Okay. Well, I think unfortunately, some of these decisions, I think many will find are beyond our control, even within our own institutions, because of restrictions that are placed on what kind of surgery should and shouldn't happen. And as you say, it's a balance between if we think that by leaving the spleen in, that you're going to obviously have the morbidity in addition to the fact that you won't be able to transfuse them, it makes sense. But as we're all facing, these decisions are beyond our control. If you can convince, and we have been able to convince our surgeons to get some procedures done that we think are pressing, if you're able to convince your surgeons in your institution to have a procedure done that a patient needs, that is going to reduce their morbidity, reduce their need for blood transfusions, etc., then I think you should. But I'd agree that but there obviously has to be a negotiation between yourselves and your surgeons and your policy.
Okay, thank you very much. Now I will go to the questions for Dr. Arwa Riyami. Bunch of very interesting questions, and let's start with this one. Is convalescent plasma safe for immunocompromised patients, like oncology patients with COVID-19?
Well, that's a very, very good question. I don't think any of the previous clinical trials have looked into the underlying comorbidities in patients other than age and other non-comorbidities, looking into the different side effects of plasma transfusions like TACO. for example, but I haven't seen anything that was actually looked into oncology patients.
Yeah, obviously it's not realistic to be asking a question like that in, you know, with the very well-known limited experience. But I guess, you know, people were you know, trying to check if it is physiologically or in theory, if there anything against it if we happen to have an oncology patient who happened also to acquire this COVID-19. Yeah, I will stop at your you know, answer and switch maybe to another question, which is this question from Adla al-Makhyami. Okay. Can titration of plasma and use of rapid IgG, IgM test be an alternative to ELISA to detect the titer of antibodies in convalescent plasma?
Mm-hmm. So that's a very good question. At the moment, there is a lot of studies that are going on with regards to validation of the different titration tests that are out there. There are many tests that are commercially available at the moment, which are ELISA tests. The problem is that none of these have been validated rigorously for COVID-19 infection. And there are many studies that I'm aware of that are looking specifically into this. The other thing also is whether total antibodies are going to be as reflective as IgG or IgM or IgA. No one really knows which of these subtypes of antibodies is really when we are assessing for the antibodies. Countries have actually decided to collect samples and basically do the convulsion plasma treatment. And whenever studies are published on validation assays, then test these samples, archived samples at a later stage, while others have actually decided to go ahead with whatever is actually available now commercially. It's very important to make clearly that there's a lot of work that is going on in parallel with initiation of clinical trials of actual treatment, looking into these tests, looking at the different neutralizing assays and how they also are comparative to these fast tests. Because the thing is that you might have a test that is indicating for you that you have a sufficient level of antibody that is detected in the donor, but that may not translate well in a validated way to the neutralization activity of the antibody. So there's a lot of work that is going on in looking into this aspect at the moment.
Okay, from the same person, the question is, what is the best day for collection? 21 or 28 days
That's
if antibody test will be done post-collection?
Yeah. So the peak of the IgG antibody does occur between the 14 and the 21 day. The half-life of the antibody basically starts at 28 days. And hence, collections generally are recommended to be at 14 and beyond, with exception of this new release that came from FDA that you can do collections before 14 days. You don't know what the titers will be like at that stage. But 14 and beyond is considered to be quite reflective of sufficient level of the antibody titer. And beyond 28 days, there are some previous studies that looked into antibody levels in SARS and MERS, and they have found that the antibodies do persist beyond 28 days, and hence they can be collected afterwards. But many of the trials and the protocols that I'm aware of, they are either collecting at 14, provided that the donor has been tested twice and considered negative, or they collect at 28 days without any fear that the donor might still be viremic. So I would say in between, you can basically collect anytime. Yeah.
Okay. There is a question as well about
May I have a question about
yeah, sure.
this?
Yeah, sure.
Because we in Spain we are starting to test also asymptomatic people. So we suppose that there will be a proportion of the population that will be positive for coronavirus, but they will not have been never diagnosed. So perhaps they can be also a very good source of plasma, and even better because for any reason they did not get ill.
Yeah, that's very good, because I think the European Commission guideline is kind of open a broader scale of who can be tested. I actually have seen that they have included this in there, that you might have patients who are quite mild in the disease and hence may not have conferred a very clear infection manifestations, but they do have antibodies. So yes, I've seen that, and I think that's why the scale of testing is quite big. And I know that in UK, for example, they are also looking into large scale of collection as well.
Thank you.
You're welcome. Thank you for the question.
Okay, any, I guess from the speakers, any more questions? Dr. Syed, is well known for his questions in all the meetings I've attended. Do you have any question, Dr. Syed Osman?
Not this time. Thank you very much, Dr. Mohammed.
Okay. Well,
but thank you very much to the other speakers, and actually thank you to all of you.
Yeah, that was a great actually participation from all the speakers, and I thank really all the people who attended and had the time to participate and post all of these questions that I have picked from them, some of the most relevant ones. And I would to remind everyone to do the polling and to fill out the survey by the end. And thank you again to all of our speakers for this great participation and great talks. And probably, inshallah, we will see you again in another webinar.
Inshallah. Thank you very much for the invitation and for the engagement I've got from the attendees. Thank you.
Thank you very much. Thank you.
Take care. And stay safe.
Yes, same to you.
Yeah, one final announcement. This whole webinar is recorded and it will be available in the Saudi Society for Blood Disorders website, and it can be reached. Thanks. Bye-bye now.
Thank you, Dr. Arwa. Thank you, Dr. David. Thank you, Dr. Mohammadi, Dr. Uthman. And thank you for all attendees, as well as for Sanofi for their support.